Healthcare managers often start clinics and programs. They need to understand how much to charge for the services offered through their new investments. They need to justify the effectiveness of clinics to various funding agencies. They need to identify weak and money-losing operations and work on improving them. Unfortunately, the cost-effectiveness of clinics is not always clear, as it is difficult to distinguish program cost from other expenditures in the organization. Many clinicians have multiple roles within the organization. It's not clear how much of their time or effort is going into the new program or clinic. It's difficult to understand how personnel, management, and other indirect costs affect the viability of the new clinic. To make things more confusing, new clinics share facilities with existing programs, making it difficult to charge them rent or allocate portion of capital expenditures to these clinics. A rational approach would require us to isolate the cost of the program from other costs and decide how much of the overhead should be carried by the program. This lecture is about how to do so. In addition, program costs are just part of the picture. The other side of the issue is measuring the benefits of a program. Any program or clinic not only has its own services, but also affects the services offered by other units. Offering a new program in cardiology, for example, might help identify patients for home health care services. If the new clinic is more modern and advanced, then existing operations would be affected. For example, if it has an electronic medical record and it uses new surgical equipment, they might change the image of the entire organization and affect the referral to all existing clinics. In short, any new clinic investment may have many consequences. If we are to evaluate it accurately, we need to track all of these consequences. This lecture shows how healthcare managers can isolate the cost of a clinic and trace the consequences of its services through use of decision analytical tools. To demonstrate our ideas, we show how we applied them to evaluation of the cost-effectiveness of co-locating a substance abuse treatment clinic within a probation agency. Over 4 million adults are under probation or parole supervision. Supervision failures, often linked to return to drug use, create a cycle back into prison and jails. If supervision can be enhanced with treatment, then perhaps the cycle can be broken and offenders can return to the community, not only restoring their lives, but also perhaps saving money associated with crime and return to prison. We used a decision analytical model to evaluate the cost-effectiveness of co-locating substance abuse treatment clinics within a probation agency, the so-called seamless probation. The decision model compares the seamless probation to the traditional model of providing probation and substance abuse treatment separately. In any analysis, the perspective of analysis dictates whose costs are included. If one is analyzing costs to the patient, then costs to the hospital are not included. If one is including costs to the organization only, then costs to the external agencies are not included. A societal perspective may include costs incurred to caregivers and other social components of care. If the analysis is done for payers, then costs to these organizations are included and other costs are ignored. In the seamless probation study, the focus of analysis was costs and benefits to the government agencies that were expected to fund the clinic. We need to decide how far in the future we want to look for consequences of opening a new clinic. Many of the benefits may occur several years later, for example in reduced hospitalization, while costs occur during the clinic visits. It is therefore important to define precisely the time frame for cost-benefit analysis to discount future returns to current values. For example, the benefit of a seamless probation shows years later in the form of reduced crime. To capture these, a sufficiently long perspective is needed. The study on seamless probation examined the effect of substance abuse clinic for 2 to 3 years after enrollment in the study. This is long enough to see the impact of a short-term events, but of course not long enough to capture lifetime events. We recommend to you 5 steps for conducting a cost-effectiveness analysis using decision trees. First, create a decision analytical model that includes the clinic utilization, clinic operating cost, and impact of clinic on other costs. Second, estimate the various daily probabilities needed for the decision tree. These include the probability of clinic utilization, keep in mind that it has to be measured on a daily rate, and the daily rate of various consequences. Third, estimate the daily cost. This is done for both the clinic operations cost, which is estimated from clinic budget, as well as for various consequences of the clinic, which is done typically from the literature. Fourth, calculate expected cost of the clinic. And fifth, conduct sensitivity analysis to see if your conclusions change based on changes in the parameters. Let's go through these steps. In step 1, you create a decision model. Decision models have been used to model costs and benefits of a wide array of services. The typical analysis starts with the decision node contrasting joining the new clinic and the usual or standard care alternative. Then the various events within the program are indicated, for example, treatment retention. In the figure, this is shown as a visit. Since the analysis is done per day, we show this as a day in which a visit has occurred. Next, 2 costs are reported: the cost of the program and the cost of consequences of the program. The cost of the program refers to the personnel, material, information system, building, and other capital and operating costs of delivering the program. The cost of consequences refers to subsequent costs that the patient or the organization may incur. For example, a clinic visit may lead to additional referrals or in some cases to a hospitalization. The cost of the consequences is itself a separate decision tree. In the figure, this is shown as node C. This node is broken into a more detailed tree. For example, we are assuming that after the clinic visit, the patient may be hospitalized or sent to the specialist. In addition, the figure has a placeholder for other major events that might occur as a consequence of the clinic visit. Finally, to make the list of possible events complete, we need to also include the situations where none of the major events imagined will happen. Strictly speaking, the events depicted must be mutually exclusive and exhaustive. Some events, for example visiting a specialist and being hospitalized, may co-occur on the same day, and thus may not be mutually exclusive. If this co-occurrence is not occurring often, then the analysis can be considered an approximate. One advantage of a decision tree is that it separates the probability of an event from its unit cost. For example, in this figure, the probability of a day of hospitalization is separated from the cost of a day of hospitalization. Unit cost of services are unlikely to change under different alternatives. Therefore, we do not need to estimate these costs for each alternative. For example, while the new clinic is expected to affect the probabilities of hospitalization, it's not expected to affect the unit cost of a day of hospital care. Since unit cost is the same under each alternative, changes in these costs are unlikely to affect the analysis in significant ways. Therefore, we can use national estimates for these costs and not need to collect data to assess these costs within the organization. Decision analysis makes data collection easier and perhaps more accurate by reducing the number of estimates needed and using national estimates for components that do not change under various alternatives. This figure shows the overall structure of the analysis for seamless and traditional probation. The left section of the tree depicts the decision. Immediately after this node, the probability of receiving 1 day of probation or 1 day of treatment is shown. These branches indicate utilization of services. The middle section of the tree depicts treatment and probation outcomes, what we previously called consequences of clinic visits. We assumes that probability for a day of homelessness, a day of unemployment, a day of foster care for their children, a day of hospitalization, and a day in prison will vary with clients' probation and treatment status. The right-hand section of the tree depicts various costs associated with each path in the tree. These costs are measured per client per day. Since the analysis relies on daily probabilities of the events, cost must also be estimated per day in order to remain consistent. This section discusses how the probabilities needed for the analysis are calculated. There are 4 ways to assess these probabilities. The first method is to follow a large cohort of patients, preferably randomly assigned to various alternatives, over time and count the frequency of the events. This method is objective, requires considerable follow-up time, and access to a large number of patients. For example, we might follow 100 patients in our clinic and report the frequency with which they are hospitalized. The second method is to examine time between reoccurrences of events in a decision tree. If we can assume the daily probability of the event has a binomial distribution, then time between the occurrences of the event has a geometric distribution, and the daily probability can be calculated by number of days in between the reoccurrences given the formula depicted here. This method is objective, but requires a shorter follow-up time than the first method, especially if the probabilities being assessed are relatively small. For example, the daily probability of hospitalization may be calculated as number of days before the patient is hospitalized. If a patient is hospitalized after 80 days, then the daily probability of hospitalization is 1/81. The third and fourth methods are same as the first two, but based on experts' opinions and not objective data. We might ask about days to the event or the frequency of the event from our experts. We might ask a clinician how many days before a patient is hospitalized, or we might ask an expert about the patient's prognosis by asking them to specify the likelihood that the patient might be hospitalized within the next 30 days. In the seamless probation example, we used the first method. We recruited 272 offenders with extensive criminal justice histories and randomly assigned them to seamless and traditional probation. Offenders were interviewed at baseline and at 3 12-month follow-up periods to examine their utilization of various services. Of the clients, 78% of the clients on traditional probation and 77% of the clients on the seamless group were available for follow-up interviews. When assessing objective frequencies, it's important to keep in mind that decision trees requires the calculation of daily probabilities of various events. These probabilities are calculated by dividing the length of time of an event occurs, for example, number of days of hospitalization, by the total number of follow-up days. When calculated in this fashion, the probability of 1 day of an event is affected by the duration of the event. For example, client's length of stay in treatment alters the probability of a day of treatment. The longer the treatment program, the larger the daily probability. A client who is in treatment for 1 year will have a daily probability of 1. A client in treatment for 1 month in a year will have a daily probability of 8%. As clients stop and restart treatment, the daily probability changes. The proposed method of calculating probability of the event takes into account multiple returns to treatment. Data shows that the clients in the seamless group had more treatment, more probation, lower arrest rates, but also more technical violation instances where probation officers jails the clients waiting to appear in front of the judge. The clients in the seamless group also spent more days in prison and jail despite the fact that they were arrested less often, in part because they had more technical violations. The decision tree in this figure depicts 8 pathways. By convention, the probabilities of events in a pathway are conditioned on the events preceding them. In the tree, treatment occurs after participation in probation. Therefore, we need to show the conditional probability of the treatment given probation. Conditional probabilities, as discussed in previous lectures, are calculated by restricting the universe of possible events to the condition and then examining the joint frequency of the event and the condition. In this case, the conditional probability of probation and treatment is calculated by dividing the joint probability of these two events with the marginal probability of being in probation. For example, using our data, the conditional probability of clients in seamless probation seeking treatment while they are in probation was calculated as 0.14 divided by 0.45, which equals 30%. In contrast, the same conditional probability for clients who were in a traditional probation was 13%. The daily cost of a clinic or program is calculated from dividing the total cost of a program by the number of days clients were enrolled in the program during last year. Total program costs are estimated from the organization's budget. Typically, the budget provides cost of personnel, supplies, equipment, buildings, and information services. Not everything shows in the organization's budget. To the costs available in the budgets, one adds the market value of the buildings, volunteer services, and unaccounted retirement cost. Economic cost of a clinic differs from accounting costs as it includes the value of assets or personal services donated to the program. For example, accounting procedures usually depreciate building costs. This distorts real market value of the asset. When a picture of true economic cost is established, then costs are allocated to various programs within the organization. Sometimes these allocations are clear, as when the budget of the clinic is separate from other operations. Other times, costs of various programs and clinics are mixed together in the same budget, and an allocation scheme must be decided upon. The table shows an allocation scheme for various components of the budget. The cost of many budget categories are allocated to the program using the activities of employees. First, time spent by program staff are estimated. Then the budget is allocated proportionally. The key for allocation of organization's budget to program costs is the determination of personnel activities. Clearly, some personnel will have dual roles, and it's important to ask them the percentage of time they work on different activities. This is typically done by a survey of employee activities. Because of the focus on employee activities, this approach to cost estimation often is called the activity-based costing, or ABC. In the seamless probation, 2 new operations were introduced: a new clinic for providing substance abuse treatment and a new way for doing probation. The study estimated daily cost of both operations. The daily cost of providing the probation was calculated from the budget of the probation agency, and 2, the market value of items not in the budget. These included building cost and cost of information services. This table shows the total agency budget and allocation of these costs to various activities: investigative reporting, seamless supervision, and traditional supervision. Note that this allocation was done using what probation officers were spending their time on. A similar procedure was followed for cost of the substance abuse treatment clinic. This table shows the total budget of the clinic and its allocations to 3 programs within the clinic. Like before, items that did not show in the budget of the clinic, for example centralized management cost, were added to the accounting cost. A key factor in estimation of cost per day of service is the estimation of number of days of enrollment, what we call program census. Errors in calculating program census could lead to surprising results. Very expensive programs may show with a low daily cost if one overestimates program census. Likewise, inexpensive programs may have a high daily cost if the census is estimated to be low. Given the importance of census in calculation of daily cost, it's important to have an accurate estimate of this factor. Note that number of days clients are enrolled in the program is not the same as number of visits. Clients stay in a service even when they do not visit the clinic. There are 3 methods to estimate enrollment days. If admission and discharge dates are available, enrollments can be measured from the difference. Sometimes this data is not really readily available. In a second method, the clinicians can be asked to estimate their panel size during last month. Then enrollment days are calculated as 365 times the panel size. The third method is to look at time between most recent discharge and admission dates for the clinician. All 3 methods are subject to errors, as clinicians may overestimate their panel size, and historically, discharge and admission dates may not reflect recent patterns. To make a more stable estimate, the enrollment dates estimated from the various methods can be averaged. In addition, the range of the estimates can be used to guide the sensitivity analysis. Note that the data in the table shows estimates of the enrollment days using different methods. The estimates vary a great deal. In 2 programs, the 2 estimates are close to each other, but for the outpatient program, the 2 estimates are considerably different. Typically, daily cost of consequences does not change across alternatives. The clinic and the standard care will differ in the frequency of occurrence of various consequences, but not the daily cost of each occurrence. Therefore, these daily costs can be estimated from national or regional values available through the literature. For example, the proposed decision tree analysis for seamless probation separates the probability of arrest from its cost. Because cost of arrest is unlikely to change within the use of seamless probation program, national estimates were used for these costs. This table shows the estimated cost of arrest and court processing in 2001 projected to 2004 values. This table shows the daily cost of various consequences as estimated from published national or regional data. The cost of a day of employment was the exception to the rule. This cost was estimated by the tax paid by the offenders on legal income they had during the probation period. The expected cost for seamless and traditional probation was calculated in 3 steps. First, we calculated the expected cost of the consequences by multiplying its probability by its cost. This is shown in column 4 through 10 of the table. Next, for each pathway, the expected cost of the pathway was calculated. This was done by summing the expected cost of consequences, rows in table, and multiplying the total by the joint probability of events in the pathway. That's the product of probabilities in column 1 and 2. Finally, the expected cost of seamless probation was calculated by summing the cost of pathways that followed from joining seamless probation. These are rows 5 through 8 in the table. The expected cost of traditional probation was calculated in similar fashion by summing the costs associated with the pathways that followed traditional probation. These are rows 1 through 4. The expected cost for seamless probation was $38 and the traditional probation was $21. These costs were per follow-up day per client. The net difference was $6,293 per client per year. Seamless probation had led to reduced arrest rates, but this saving was not enough to compensate for the increased cost of mental hospitalization, the increased cost for delivery of seamless probation, additional costs due to increased use of prison and jail, and increased cost of providing treatment. Therefore, co-locating the clinic within the probation agency had not led to the anticipated savings. In any analysis, numerous assumptions are made. Sometimes assumptions can be wrong without changing the conclusions of the analysis. Other times, parameters needed to be estimated precisely because small variations in estimates could reverse the conclusions. Sensitivity analysis can establish if assumptions are significant enough to change the conclusions. For each parameter in the decision tree, a break-even point is found. The parameter is changed until the conclusion is reversed. The percentage of change to reach the break-even point is reported. In addition, where alternative estimates are available, the other estimates are used to see if conclusions change. Decision makers are often concerned how much confidence they should put in an analysis. The statisticians answer these concerns by measuring the statistical significance of differences between new clinic and standard care. In decision analysis, we take a different approach. One way to help decision makers gain confidence in the analysis is to conduct sensitivity analysis. First, single parameters are changed. Then two parameters are changed at the same time. Finally, multiple or more than two parameters are changed. If conclusions are insensitive to reasonable changes in the parameters, then decision makers gain confidence in the analysis. This table shows the sensitivity of the conclusions in the seamless probation case to changes in rates of any one of the consequences. There was no change in any single rate that would change the conclusions. Even when arrest rate of the seamless probation was set to 0, the traditional probation was still more cost effective. The break-even points were examined for simultaneous changes in several variables. A 54% reduction in all adverse outcome rates would have made seamless probation more cost-effective than traditional probation. The analysis was most sensitive to reductions in arrest, mental hospitalization, and incarceration rates. A 57% reduction in these three rates would have made seamless probation more cost-effective. When examining the sensitivity of conclusions to simultaneous changes in two rates, the analysis was most sensitive to changes in mental hospitalization rate and incarceration rates. A 69% reduction in these two rates would have made seamless probation more cost-effective. The sensitivity of conclusions to changes in any one of the estimated daily costs was also examined. Note that both the traditional and seamless probation have the same daily cost for all adverse events, and therefore small changes in these estimates are unlikely to affect the differences between the two groups. For example, the daily cost of arrest is the same for both seamless and probation. The cost of arrest had to increase by 8-fold from $6,818 to $57,721 before the conclusion that traditional probation is more cost-effective was reversed. This analysis suggests that small variations in daily cost of adverse outcomes were unlikely to affect the conclusion. So, what's the take-home lesson? This lecture has shown how cost and effectiveness of a clinic can be examined. A decision tree allows the calculation of cost effectiveness to be broken down into several separate estimates. These include assessing daily probability of enrolling in clinic services, daily probability of facing various consequences, daily cost of clinic operations, and daily cost of various consequences. The latter is available through the literature, and the former variables can be measured through tracking a large cohort of patients or through asking them clinicians about them, especially if we ask about time to these events. A combination of tools, decision trees, probability estimation tools, and activity-based costing, as well as judicious use of data available in the literature, makes it possible to analyze the cost-effectiveness of a new clinic or a practice